Hi, Anne Davey here from Massage and Myotherapy Australia. On the next episode of Connect, we hear from our friends at Massage New Zealand and the excitement of our conference in New Zealand next year. We also have John Gibbons talking about the anatomy of the lumbar spine disc, and I also sit down and have a chat with Ryan Hutton from NIB and his role on the Private Healthcare Australia. See you then.
Kia ora, I'm Florence.
Kia ora, I'm Bernie, and we're the co-chairs of Massage New Zealand.
We are very excited to be returning to an in-person conference in 2023.
We will be partnering with Massage and Myotherapy Australia and giving our Aussie friends a big New Zealand no mai haere mai welcome.
The 2023 host city is Auckland, and the conference will be held on the 27th and 28th of May.
For more information, visit massagemyotherapy.com.au. And from all of us Kiwis,
where the bloody hell are ya?
Hi, I'm Anne Davey from Massage and Myotherapy Australia, and welcome to this episode of Connect. I'm here with Ryan Hutton from NIB. Welcome, Ryan. Nearly called you Hutton.
You nearly called me by my surname. That's okay. No problem. I've been called worse.
Good to see you. So I think it was about this time last year we had a chat and you were working for Bupa, but now you're working for NIB, which is pretty awesome. They get your skill set from Bupa, I suppose. But what's your role now? Because last time I think you had a 3-sentence title. So
I did have a 3-sentence title. It's pretty simple now, which is fantastic. So it's just the product owner, provider management, which is really nice and simple to say. I guess, the big part, though, is that it has changed. So my previous role was about industry relations and the ancillary network or general treatment allied care network. My role here at NIB has diversified to including relationship management for both our hospitals, our doctors and medical providers, as well as our ancillary and general treatment providers, and the new and emerging area of hospital substitution and home care.
Oh, wow. That's massive, isn't it? So
Great.
It is good. Keeps you busy. So I suppose, I'll deep dive into every health fund audits. Random audits, targeted audits, whatever you want to call them. An audit is always a scary word for everybody. What are you looking for when you're auditing our practitioners? And they shouldn't be afraid, should they?
Yeah, look, I think you've just hit the nail on the head. They shouldn't be afraid. I think one of the things we do need to look for and understand is that we are paying for the services and benefits that we pay in line with what the rules are. So we know we have rules that govern how we pay benefits and when we pay benefits. So the whole premise of paying benefits is around the treatment of an identified clinical condition. And so when we look to audit providers, we are looking to ensure that we are paying benefits appropriately, we're paying benefits fairly, and we're also making sure that there are those, unfortunately, in the market that sometimes don't do the right thing. And we're making sure that we do provide some sort of framework and governance structure to ensure that we identify where that's happening, mitigate that risk, and ensure that we are recognising and paying benefits in the right way to the right providers for our customers.
And it's not only about the funds, is it? Like the what you're paying out, it's also ensuring that your members are being treated appropriately and that there's clinical records, all those sorts of things.
Absolutely. And I think it's not just about the clinical record keeping. I think a lot of your members will be acutely aware of what happens in this space, and it's making sure that our members are being seen by qualified, whoops, the lights have gone out. My apologies.
There you go.
By qualified and medical practitioners. So, in terms of us and all the funds, we all have our recognition criteria that stipulates, the minimum certifications required for recognition by the fund. And we're making sure that those services that are being delivered to our members are being delivered by those individuals.
Which is why we're here as well. We help ensure that.
Yeah.
Also, yeah. So rather than just focusing on provider numbers and audits, I mean, the front of mind for our members is having a provider number. How do I keep it? How do I maintain it? How do I get it? You have another hat, which is with the Private Healthcare Australia,
Yep.
Correct? Yep.
Yes,
So
that's correct.
what is Private Healthcare Australia?
So Private Healthcare Australia is a body that represents the private health insurance sector. So the funds are able to become members of Private Healthcare Australia, and the funds that do or are members represent over 13.5 million Australians that have private health insurance, which is 97% of the market. The premise of us working together collectively as funds is around making sure that we have a response for changes that are required in industry, for reviews that are being passed down to us by government authorities, and to make representations and submissions for positive outcomes and change within our industry. So rather than individual funds having to do the legwork for this, and there's a bigger industry, benefit to making a holistic change, that's where the PHA can come in and offer that sort of united front and support in terms of having those changes made.
Right. So it's almost like it's an association that
it's an association. Absolutely. It's an association. So, so my role with the PHA currently at the moment is as the chair of the general treatment community of interest, which is basically all of your general treatment providers. We have representation from, as I say, each of the funds that are members of the PHA. And my role as chair is over a 2-year period, and then it will rotate. And each fund will have the opportunity to put forward a nomination to chair that group. And then from that group, we then have sort of smaller working groups that are sometimes formed and established to help identify or help support the various modalities or providers in making changes within their sector.
So one change that you and I have discussed, and I know you've discussed it with other associations as well, is to have an in-home care item number.
Yep.
Correct?
Yes, that's correct.
Which would be what?
So we know that the delivery of healthcare has changed, particularly after COVID. I think that's probably the big thing that everyone knows has happened over the last sort of 2 years. Yeah. What we've seen is a higher propensity of the consumption of healthcare to occur in the home. And that's just because of a couple of factors. Number one, lockdowns meant that people couldn't leave home. Number two is people have changed the way that they engage with community. We're seeing a lot more people working from home these days. We're seeing a lot more, I'm just making sure the light doesn't turn off, making sure that they've got access where it's appropriate. And also there are some of those individuals, unfortunately, that perhaps shouldn't be out in public at the moment because of their own personal safety, whether they're, not unwell or whether they're unable to leave home for various reasons. We're seeing a massive increase in in-home care. And so regulation of how that works and how that would be applied is the reason why I've sort of spoken to yourself, Anne, about the need to have a differentiated item code that represents those individuals that do deliver in-home services.
Yeah, and that would link in with the updates to the hand claiming machines that now have geomapping, correct?
Yeah, absolutely. And you know,
Mm.
look, that's part of the thing that has come about, is that we're seeing advances in technology which help to
Yeah.
pinpoint where services are taking place. We all know
Mm.
that a provider number is a location specific
Yeah.
provider number. So you can only have it which applies at the place of practice that you work. You must have one for each place that you work. Now, obviously, you're not going to have one that represents every single patient you see if they're in their home. And so what we're actually seeing now is the ability for us to identify where that service is taking place. If it's taking place away from your registered place of work,
Business. Mm-hmm.
there's legitimate reasons for that. And that could be
Yeah.
because of in-home care. And so being able to identify those instances where care has been delivered in the home is something that's an enabled capability now through these new terminals, as you say, Anne. And so that will help a lot of people, particularly those providers within your membership base that operate mobile only provider services.
Absolutely.
So, yeah.
Yeah. And it is such a broad area, because you can have, someone with Parkinson's, for instance, or somebody very pregnant who just can't drive, who needs pregnancy massage, or end of life, or chronic pain and they just can't drive. So it's not just about moving into a mobile environment. It's about actually providing a specific medical service.
Correct. And this is the thing, like if you look at, the recognition criteria that goes into place when we do apply for provider numbers for individuals, we look at the clinical setting in which the service is being delivered. So we know we've got rules in place that says, your practice must adhere to certain conditions around infection control, safety, et cetera, et cetera. We want to make sure that those very same principles apply to where the service is being delivered. And so, being able to administer and deliver care in the home is important. Yes, we want to make sure that it's being done in the care and safety of a setting that's appropriate. So therefore, identifying where that service is taking place, be it in the home or in the place of practice, is really, really important. What we perhaps don't want to be, seeing all the time is where we're seeing remote care being delivered outside of those settings. And that's probably really, really important to understand, is that what we're identifying is that, there aren't any breaches or potential breaches of privacy of patient, of care of patient, of safety of patient, if they're not being administered care in an appropriate setting. So,
and healthcare has been in the home for a very long time. Your district nurses, for instance.
District nurses, look, there are other modalities within allied healthcare. Physiotherapy has had in the home item codes for many, many years, as have occupational therapists. And we're obviously seeing a lot of advancement in telehealth technology with, mental health, intervention. So remote delivery of care and to your doorstep care has been in place for quite some time. Absolutely.
Yeah. Oh well, we've got some work to do on that, haven't we? So
I think so, but I think it's also doable. And I think this is the thing, right? I think one of the things we've got to look at is this is an opportunity for us to actually expand how we access care, or how our customers access care, or how your members' patients access care. So these are the types of things, if we can implement them, will actually probably prove to be beneficial. We know that there are funds. Some funds may choose to recognise or not recognise, but at least it gives those funds the choice. And that's the key. Not all the funds work together collaboratively to recognise services equally, okay? And so being able to have the differentiator of being able to say, yes, I want to recognise in-home care, is important for those funds that do want to recognise it. Highly encourage, the opportunity that has been presented to us. Absolutely.
Awesome. Well, I think, hopefully, we can move forward with it. And I'm sure the PHA, Private Healthcare Australia, has lots on its agenda for the future for the health fund industry. It's always in the news, isn't it? So,
look, it is. And I guess one of the, things for perhaps your members in particular as well, is that we obviously and one of the probably ones that they'd be familiar with is the Natural Therapy Review Board. So a lot of the responses to the government and to the Commonwealth about those certain services which have currently been restricted is coming as a united front from Private Healthcare Australia about what to do next. And so that is a piece of work that we are working on at the moment.
And we're waiting for a response, aren't we? That got delayed because of COVID.
Got delayed because of COVID, got delayed because of the election. So we are waiting,
Yeah.
to see what the Commonwealth does. So the submissions have been put forward by the various groups that do want re-recognition. So we are waiting to see how that disseminates into a change. So
yeah, because we do have a lot of members that are not just massage therapists or remedials or myos, they're naturopaths as well. Which is one of the modalities. So anyway, well, it's great to catch up, Ryan. Thank you so much for your time, and I'm sure we'll probably do this again. So
not a problem at all.
All right, thanks, Ryan.
Thank you.
In this video, I'm going to talk to you about pathology of the lumbar intervertebral discs. There are 23 intervertebral discs, and if we look at the anatomy of one to start with, then the outer covering along here, okay, is known as the annulus fibrosus, and then the inner center is known as the nucleus pulposus. Now I've got 3 discs here, so this would be a normal looking disc. So the nucleus is contained within the annulus, and I'm not sure if you can see, but on the outer part here there are circles like concentric rings, and they are known as the lamella, and you have roughly between 15 and 25 of these concentric rings here. And basically one ring travels in this direction, the next one travels in this direction, and so on, because it gives its resilience. Now, so it's mainly a water-based type of substance, and naturally as we get older, the disc over time can actually deteriorate, and then we have something called like degenerative disc disease. Now the problem is with a disc is that it can go through stages of a bulge, it can also protrude, extrude, then it's obviously going to progress to a prolapsed intervertebral disc or a herniated intervertebral disc, and then finally it can actually separate and be known as a sequestration. And if you're looking at this one here, you can see the fluid now is starting to bulge along here. You might not get any symptoms with this one. You might find that if it's within the annulus, you might get some localized back pain, but you might find many people will have a bulge of a disc but have no symptoms. When it slowly progresses to something like this, so this would be a prolapsed intervertebral disc, then no doubt that is going to contact something. There is a ligament posteriorly known as the posterior longitudinal ligament along here, and you might find that is very painful if the fluid touches that ligament, so your back hurts. You're not going to get any neurological symptoms into the leg because there's probably no contact to the nerve root. However, if it's gone to this stage like this one, and also on this one here, where the fluid is exiting, tends to go posteriorly laterally, and then you might find the nerve root at exit is going to be contacted. And if I show you on this one, the thing is with a lumbar spine, which is different to the cervical spine, is that within the lumbar spine, if this one is say L4 and this one is L5, then the nerve root at exits is below. So this is going to be L4 nerve root, and then this one is going to be L5 nerve root. So you probably find that if a disc exits to the side, is going to contact the L4 nerve root, which is fine. However, if I to lift up this here and show you, you might find that if a disc has prolapsed, it doesn't actually contact the nerve root at exits, it contacts the nerve root that goes down. Okay, so it's called the traversing or descending nerve root. So that nerve root here is going to contact, if you can see it just there, is going to contact not the one that exits the level, it's going to contact the one that exits below. So you might find if this is the L5 and S1 disc, then you might find that it doesn't contact the L5 nerve root that comes out, it contacts the S1 nerve root. So just bear that in mind, because within the cervical spine, if you have a disc prolapse between C4 and C5, the nerve root is above the level. So that's going to contact the exit nerve root of C5, whereas in the lumbar, it will change. So there's a little bit about discs in the lumbar and a little bit about nerve root compression as the nerve root exits. I hope you've enjoyed the short presentation, and thank you for watching.